Hello, everybody, and welcome to today's webinar. Thank you for joining us. Today, we'll be looking at leveraging OMOP CDM for better research. That stands for Observational Medical Outcomes Partnership Common Data Model for better research. As we wait for others to join the webinar, we have a fun icebreaker question for you there on the screen. If you could only eat one cuisine for the rest of your life, what would it be? Feel free to put your answers on chat or come off mute. Thanks again for everybody who's just joining the webinar. Welcome to today's webinar. We have a fun icebreaker question for you on the screen before we kick off. If you could only eat one cuisine for the rest of your life, what would it be? And I see answers coming on chat. Feel free to come on chat or come off mute. So I see Italian, yes, Italian, definitely Mediterranean, pizza, Indian cuisine, very nice, very nice. For myself, I wouldn't really say a cuisine, but I'd say a meal, I don't know, spaghetti and meatballs for me, just any day, anytime. Easy to cook, easy to eat, easy to digest. But anyway, keep on putting your answers in. And thank you again for joining today's webinar on Observational Medical Outcomes Partnership Common Data Model. We will begin 5 minutes past the hour. Again, welcome everybody to today's webinar. Thank you for joining us. We'll begin in the next few minutes. We'll wait for everybody to settle in. We have a fun question for you on your screen. If you could only eat one cuisine for the rest of your life, what would it be? Feel free to put your responses in chat. I see very many interesting responses coming in. So yeah, feel free to come off chat, put your responses off chat as we wait for the room to settle and we can kick off today's webinar. Hi, everybody, and welcome to today's webinar. For those just joining, we have a fun icebreaker question for you on the screen. Feel free to respond on chat or come off mute. And we're going to start the webinar in the next minute. I see very many interesting answers coming in chat. Italian, Mediterranean, Indian, pounded yam, and oha soup. Oh, I've never had that. That sounds interesting. Frank says dumplings, they have great flavors and ingredients inside. Yes. Thank you for all your responses to our icebreaker question. I think we can now kick off our webinar. So we'd want to kick this off with just a short poll question to understand your understanding of global goods, your knowledge of global goods. So what we're asking is, how would you rate your overall knowledge of global goods? Not much, I know quite a bit, or I know all about global goods. Kindly respond to the poll you see on your screen. Okay, just to iterate, we have a quick poll question for you on the screen. How would you rate your overall knowledge of global goods? Not much, I know quite a bit, and I know all about global goods. Kindly respond to that poll question so we can be able to gauge your knowledge of global goods. Okay, so thank you all for your responses to that poll question. I'm just looking at the results for that. Okay, we see 62% say not much, 31% say quite a bit, and 8% know everything about global goods. Okay, so we'd want to move each to the other side, so not much to quite a bit and quite a bit to I know everything. And I hope today's webinar will take us closer to that. So to begin, I'll just give, I'll let you know the agenda for today. So I'll give you a short introduction to global goods. Then next we'll have a presentation from the team from the community of OMOP CDM presentation, which stands for Observational Medical Outcomes Partnership Common Data Model. And then we'll have some time after for some Q&A. So to begin, I'll just give a brief introduction to global goods. They are impactful open source solutions designed to improve health outcomes on a global scale. What makes them unique is that they're open license, which means they're free to use, adapt, and share, which always fosters innovation and collaboration across diverse regions and organizations. They're health focused, which means they're specifically designed with health systems in mind, aiming to improve public health delivery and outcomes in low-resource settings. They have a strong community with clear governance. Each global good is backed by a robust community of contributors, which always ensures continuous improvement and sustainability. They have multiple sources of funding, so funding from various donors and organizations, which ensures a broad base of support for their development and maintenance. Global goods are scalable. They're designed to be flexible. They can easily be adapted and scaled for different countries and contents and contexts and health systems. There is proof of use and effectiveness. So many global goods have already demonstrated success in real-life implementation, showing their value in improving health outcomes globally. So today we're excited to announce that we've recently added 3 new global goods to our global goods collection. You can explore this along with others in the global goods guidebook. We will share a link with you on the chat. Today we'll be showcasing one of these additions, which is OMOP CDM, and we'll dive into how it works, its impact, and why it's valuable for health systems worldwide. So I'll introduce our esteemed speakers for the day today. We have George, who's a professor of biomedical informatics at Columbia University. And a fun fact about George is that he views and photographs solar corona outside of the eclipses. That just sounds so exciting and so complicated. That is a beautiful fun fact. Our next speaker is Claire, who's the Director, Observational Health Data Analytics and PhD student at Johnson & Johnson and Erasmus, respectively. Fun fact about Claire is that she has 2 dogs named Mayonnaise and Sandwich. That is just awesome. That is so witty. I wish I thought of that before I named my dog. But yeah, beautiful. Thank you for those fun facts. And thank you for giving us this presentation today. And without further ado, I will hand it over to you. I'll stop sharing my screen and hand it over to you, Claire and George. Thank you.
All right, wonderful. Thank you. Okay. So I invite George to go first and lead us through the introduction to the OHDSI community.
Thank you, Claire. Thank you for screen sharing here. So we're going to talk about the OMOP, as we call it, OMOP, OMOP Common Data Model, which is run by the OHDSI Initiative. Next slide. So OHDSI is the Observational Health Data Sciences Informatics Initiative, which grew out of something that was previously called OMOP, and you'll be hearing more about the history in a moment. OHDSI's mission is to improve health by empowering a community to collaboratively generate the evidence that promotes better health decisions and better care. OHDSI is a multi-stakeholder, interdisciplinary, international collaborative with a coordinating center at Columbia. Next slide. OHDSI has 4,000 collaborators as measured in our Teams environment from 83 countries, covering much of the world. Next slide. The way OHDSI works is that sites potentially have data local to them that have been collected, perhaps part of electronic health records, perhaps part of insurance claims, perhaps part of a government program. What they do is they take those data and convert them to the OMOP Common Data Model, which is the global good that we're talking about today. They keep their data local to their environment. Then we send a query to them if we're doing a large study. They run the query locally on their data and share only the results, but not the data centrally. Then we work together collaboratively to interpret those data and publish studies. Next slide. So in the orange in the upper right, you see the OHDSI community working together to create data standards like OMOP that we're talking today, to build tools and develop methods. On the left in green, we see the OHDSI Data Network. These are these data partners that I was mentioning. And then they work together to create OHDSI network studies. Next slide. OHDSI is a community, and so the work gets done through work groups. We have a number of work groups here. The faces are shown of the leaders of the OHDSI community who are running those work groups to get our mission done. Next slide. And we work together. We've produced many publications, 730 publications so far. And here's a social network analysis of the co-authorship of those papers. What you see is a single fuzzy ball. So we've created a legitimate, coherent community that's working together to generate evidence and improve healthcare based on this OMOP Common Data Model. Next slide. Our values are innovation, reproducibility, community, collaboration, openness, and beneficence. Next slide. And here's a picture of our common data model. Claire's going to go into much more detail. This is the ER diagram of it. Let's go to the next slide. So that's the schema. And then the vocabulary, because we're working around the world, we need to translate from each local language or coding scheme to a central one so we all speak the same language. Next slide. We'll be going through that in more detail in a moment. This common data model is now worldwide, 500 data sources. Actually, the patient records of 974 unique patients around the world have been converted to the OHDSI OMOP Common Data Model. That's 12% of the world's population has at least one of their records converted to this data model. Next slide. And this is showing that this was an independent assessment, not by us, showing that, now this is within the US, of course, but showing that OHDSI achieved the highest total value of 20, with the second highest being 14 of all the other networks and approaches for data models. Next slide. And on top of this data model sits this open source software stack so they can exploit the data model and produce evidence. Next slide. The OMOP Common Data Model was recognized by Digital Square as a content global good, and we're quite proud of that, and we're thankful for that. Next slide. And to be included in this list is a wonderful thing. So we just want to say thank you. And I think on the next slide, I turn it back to Claire.
Yes, thank you, George. So like George said, the OHDSI community is quite large, multidisciplinary, and we're spread across the globe. But it's the OMOP Common Data Model that has been recognized specifically as a global good. So I wanted to share with you a little bit of what the Common Data Model is, how it came about, and really why we are such advocates of it, and why we're so proud that it has been recognized by Digital Square. So like George mentioned, the Common Data Model was born out of something called the OMOP experiment, otherwise known as the Observational Medical Outcomes Partnership. This was a public-private partnership that was initiated in 2009, really with the idea and the goal to generate, evidence, trying to understand how different therapies, different pharmaceutical agents might be related to different outcomes. And they wanted to do this at scale. And you can see here, they wanted to do this across 10 different data sources, combining administrative claims and electronic health records. Really, this was mostly in the US, but it was a really large goal at the time. And one of the things they realized through the course of this experiment is that when you bring together data sources that are structured in different ways and maybe have different terminologies or vocabularies, that it's very challenging to generate this evidence at scale. And that evidence really is meant to be put in the hands of patients and providers and regulators. And that needs to be done relatively efficiently and quickly so that those groups can act on that evidence. So what they realized is that they needed some common way to represent these data. When they look very different and they have different terminologies, it's very challenging to realize that goal of generating evidence at scale, efficiently and reliably. So I like to share a little bit about why a common data model with a bit of a historical lesson. And this is actually really more US history, but in the US prior to 1863, train gauge, so the gauge of the tracks of a train gauge was actually determined by the companies who own the train tracks. So every different company across the US had a different gauge for how wide the tracks would be. And so I think of using this analogy, I actually think of a data model, a common data model, as the train tracks. And it's these train tracks that support our methods, which is our engine driving the evidence that we're generating. And so if you think about this analogy, if you have different gauges of track, it's very challenging to get that evidence to the people who need it. And really, in the spirit of this analogy, what that means is, you have to use these complicated apparatuses to get the train from one track to another, or to get all the people and things from one train to another, because the gauge is changing, and you can't go transcontinental on one train because the gauge keeps changing. So if we think of this like a common data model, the same is true of data and evidence. If your data model changes from database to database, it is very challenging to efficiently and reliably generate evidence, because you are constantly having to change your methods to respond to that data model. So what the OMOP experiment designed was the OMOP Common Data Model to address that challenge. And so the way I think of the OMOP Common Data Model is that it's a system of tables, vocabularies, and conventions that allow observational health data to be standardized. And it's this standard approach that facilitates rapid innovation in the areas of open source development, methods research, and evidence generation. So from OMOP, as the experiment came to a close, OHDSI grew. So OHDSI, as George shared, is this large multi-stakeholder interdisciplinary collaborative. And OHDSI, I think of it as it's many different things. But for me, it is really the curator and maintainer of that OMOP Common Data Model, that common data model that grew up as part of that OMOP experiment and has now been adopted by the OHDSI community. So I wanted to give you a little bit of a history of the model itself. So these are just the different images of how the model has grown over the years. It started with version 1 in 2009, and then we got to version 5.0 in 2014, right as around the time the OMOP experiment was coming to a close, and OHDSI was really starting to grow. And you can see I have a little image there for version 3. Version 3 was a very short-lived version, so I have a little funny image here that we don't talk about version 3, but really we just didn't really use it that much, and we moved straight for the most part from version 2 to version 4. And then, after 2014 through to now, 2024, about 10 years later, we've made some improvements over the years. You can see we're now, as George said, at CDM version 5.4. But really what we found is, as the global community of OHDSI collaborators has grown, so too has the model itself. So you can see here we've incorporated different ways of documenting the OMOP Common Data Model. We now have much more robust information available to people who want to take advantage of the Common Data Model. We have a repository that helps you map your data to the OMOP Common Data Model, known as Themis. So really, over the years, we've tried to listen to our global community, understand what their needs are, adapt the model as things shift and change, and then make sure we are supporting our community with our documentation and helping people understand how to use the Common Data Model appropriately. So like George said, this is our current entity relationship diagram. Each of these boxes is a different table in the Common Data Model. You, of course, don't need to necessarily memorize these or understand much about what each table does, but we just wanted to show you this is how it looks and how it's organized, and all the different ways in which data are represented. So thinking about the principles of the Common Data Model, it is patient-centric. So one of the things we think is very important is that everything comes back to the patient. So anything that is represented in the common data model has to be related to the patient journey in some way. We standardize both the data model and the vocabulary. Like George was saying, this is incredibly important, and I'll touch on it a little bit later, but I really do think that this standardization I think of it as the structure in terms of the tables and fields, and the content in terms of the vocabulary. So by standardizing the structure and the content, that's really what makes the common data model successful. We have domain-oriented concepts. It's a little bit of a more detail than you might need here, but just to share that this is how we organize data around different domains like conditions, drugs, procedures, etc. We can accommodate data from many different sources in one model. The data provenance and source data are actually preserved within the model as well. So when you standardize it, you actually retain your source information in the model. It is extendable and evolving. Like I was saying, we've gone from version 1 to version 5.4 because we are constantly trying to listen to the needs of our community and respond to the evolving healthcare landscape around the world. And we do try our best to be platform independent, mostly because we understand that many people use many different platforms and technologies to interact with their data. So throughout the course of our open source development and how our community has built our software tools, we try to make it so that almost anyone can use them regardless of the database platform that they have. So like I mentioned, we do try to make the OMOP Common Data Model a reflection of the community. So within OHDSI, I am the working group lead for the Common Data Model, and we meet at least once a month to discuss any proposed changes to the CDM. So anyone, even people who aren't in the OHDSI community, anybody who is using the OMOP Common Data Model around the world can propose a change or an addition to the model. We do this through our open source GitHub repositories. Really just these repositories are a way for people to communicate and interact with us directly related to the common data model. So anybody can propose a change. These changes are then discussed at our working group meetings. And if we as a community decide that it is a valid change and one that we need to make, we will move forward and incorporate them into new versions of the model. We do also have, like I was saying earlier, we do have lots of documentation. We have a website that shares all details about the model, anything you might ever want to know, down to required fields and what the allowed values are in different fields. We have very, very robust documentation. And then we also have a book of OHDSI where we've discussed not only the common data model, but pretty much everything else that George touched on, the vocabularies, our methods library, our open source software tools, pretty much anything you might want to learn about OHDSI and what has grown up around the common data model, you can learn from our book of OHDSI. So like I was saying, the way that the CDM refresh cycle works, we start with community support. We start with those changes or additions maybe that have come up that the community has decided, yes, this is something we need to do. We then use those to define a new version of the CDM. Depending on the change, it might be something like a point version, like going from 5.4 to 5.5, or depending on the gravity of the change, we may end up moving to a new major version, like a version 6. So once we define that new version and what it'll look like, we actually go to all the other working groups. So like George shared, we have quite a large number of working groups in the OHDSI community. And really what we have found is when we take a new version of the CDM and we share it with our working groups and different people around the world who are working with the common data model, we learn a lot from them in the understanding of how they utilize the common data model and what these changes, if any, might do to impact their work. So that's actually been, that was a change we made a few years ago, and it's been very, very informative and helpful to make sure that we are creating an updated version that is beneficial for everyone. Then once we get that sign off and we make any necessary changes based on feedback from our working groups, we will release code, and then our software community will begin to update our software to support our new version, and then we go through that cycle again. So I just wanted to share this with you to impress upon you that this really is a community-owned resource. The OHDSI community is ever growing and ever changing, and so is the model. And it is, there are some pieces that have largely stayed the same, but many things have changed over time, and we find that to be really important to make sure we are supporting, like I said, that growing and changing landscape of healthcare data. So just continue on, I shared with you a little bit about the model, what it is, what it looks like, how we refresh it. And then, as George said, the vocabulary is really the second piece to that. It's that, like I said, the structure and the content that really are what drives the common data model and what makes it so unique and adaptable and usable across the world. So there's a couple different things here related to the vocabulary model, but similar to the data model, the vocabulary model has continual updates to make sure that we are, responding to the evolution of terminologies around the world. The way that this works is that, like George was saying, we have these vocabulary standards so that everyone around the world is speaking the same language. If you think about, in the US, we use one healthcare terminology. In the UK, they use a different medical terminology. This looks different in China and the Netherlands, and so on and so forth. And I think there's probably no better group who understands that better than this group here. But really, so what we've tried to do is try to identify those different medical terminologies around the world, and then standardize them all into one terminology. That way, we're all speaking the same language. And when someone in the US describes, acute myocardial infarction, other people in China and the Netherlands and the UK know exactly what they mean. And that's actually been, I think, one of the real secrets to the success of OHDSI and the OMOP Common Data Model is this standard vocabulary. Because when we are all standardized to the same structure, then we can write tools and methods based on that structure. And then when we're all standardized to the same content, then we all mean the same thing when we talk about something like acute myocardial infarction or type 2 diabetes. And so it's really that content and structure standardization that I think has made the common data model so ubiquitous. And this is the same slide that George shared, but I do think it's a really nice one because it just shows you how much work our vocabulary team has done to compile these terminologies from different places around the world into one standard, so we can continue to generate that evidence together. So I really quickly wanted to touch on some of the adopters of the OMOP Common Data Model. If this is your first time hearing of it, you might be thinking, okay, like that sounds great, but who's actually using this data model? So we do have people around the world at academic institutions, hospitals, industry partners, but we've also seen quite a lot of support from different regulatory agencies, like the FDA. So I'm showing here the FDA BEST program. This is launched by the Center for Drug Effectiveness Research, I think, CBER, I apologize, Biologics Effectiveness and Safety Program. So they are really leaning into the OMOP Common Data Model and the evidence that we are generating. Now in 2019, there was another public-private partnership called Eden that was launched by the IMI Consortium, the Innovative Medicines Initiative. I think it's now been rebranded to IHI in Europe, the Innovative Health Initiative. But this program is now coming to a close, but it's called Eden, the European Health Data and Evidence Network. And their goal was to develop a network of databases throughout Europe that can be used to generate evidence. So if any of you have ever tried to identify observational health data sources in Europe, or try to find different collaborators, it can sometimes be challenging. And so Eden was developed to address that challenge of identifying available data sources in Europe. And they did this by actually mapping over 200 data sources to the OMOP Common Data Model. It has been very successful. And now as they come to the close of this project, they're actually going to be launching a nonprofit called the Eden Foundation. So now that Eden has identified and standardized over 200 data sources in Europe, the Eden Foundation is going to move forward and really drive evidence generation in Europe. And then coming out of this is actually the Darwin Initiative. So Darwin is an initiative that was that has been spearheaded by the European Medicines Agency. Really, and what they have done is they have taken the best of the best data sources from Eden, and they have developed this very specialized network designed to generate evidence for specifically for the EMA. So the EMA is, as you can tell, is all in. They are very supportive of the OMOP Common Data Model and our approach in OHDSI, which is this multidisciplinary collaborative approach of standardizing data that then supports open source methods and software development, ultimately to generate evidence. And I think what's been really interesting and very exciting for us in OHDSI to see is that the EMA is able to interface with Darwin EU to have them quickly generate that evidence at scale so that the EMA can actually act on it to improve the lives of patients in Europe. So that's been really, really exciting. And one other thing that was very exciting recently is that the European Commission actually, they denoted that the OMOP CDM and Eden in particular, that European Health Data and Evidence Network, that these two working together are actually they are cornerstones in the how Europe will be competitive in the world health space moving forward. So that has been really, really exciting for us to see, is just the uptake of the OMOP Common Data Model in Europe and how it's really been embraced by the EMA, and just the good that the Common Data Model is doing for patients. So just as a quick highlight, these are the current data partners in Darwin. And this is, like I was saying, some of the data partners that were taken from Eden, those data partners that are, that they can respond the quickest to the EMA's requests, because they do have to respond very quickly. But that's where those open source methods and tools come in. So one thing you might be thinking is, okay, great, you know, you've developed this common data model. There are people around the world who have mapped their data to the CDM. That data stays behind the owner's firewall. So we in OHDSI never have access to person level data. We are really just receiving the results of studies. So you might be thinking to yourself, well, how do you ensure the quality of that data if you can't touch it? So when Eden kind of came on board in 2019, we realized that data quality is going to be a big issue. And so at that time, we initiated the development of what's called the data quality dashboard. I won't go into all the details, but essentially this is just a way for us to have our data partners run a multitude of data quality checks on their standardized data source to help us, I make sure that they are aligning with some of those quality measures that we have determined to be important. So I know Eden uses this pretty regularly. Darwin does as well. And this is, again, constantly evolving and changing over time as we learn more and more about data quality. And as you know, there are many different agencies around the world that are continuing to evolve their understanding of data quality. And so we evolve our approach as well. So just a couple of papers if you wanted to take a look, just showing you that, this is being applied to Eden as well as pretty much every database in the OHDSI network. So thinking future, the future state of OHDSI and what we're trying to achieve. George mentioned we have over 500 data sources that have been mapped to the OMOP CDM. But what we found is that one of the great things about OHDSI is that we're open source. Anybody can utilize the OMOP CDM. Anybody can utilize our open source methods, and that's what we want. But the hard part is we don't always know who everyone is. We don't always know who to contact. There are many, multitudes of academic medical centers that are utilizing the OMOP CDM, but I don't always know the individual people at those medical centers to reach out to ask them to join our research efforts. So what we are doing starting this year, and I don't see any end in sight, is we are developing what we're calling the OHDSI Evidence Network, really so that we can facilitate collaborative research efforts and ensure the quality and integrity of data across the OHDSI network. And really, the main goal is to formalize the way in which researchers who need data are connected with organizations who have data. I think this is extremely important. We have, as George said, we have over 700 publications. It's not like research is not getting done, but we see an opportunity to really scale up our efforts and improve the way that we are communicating with our network. So we are really making a concerted effort to identify everyone around the world who has mapped their data to the CDM and identifying people at those institutions that we can reach out to really grow our footprint and grow the amount of evidence we're generating every year. So just to give you an idea, it's exactly what George was talking about, where patient level data does not leave the participating site. We are just trying to identify who these people are, who the individual data sources are, so that as studies come in, we can very quickly connect people. I'm actually very excited. We have a collaborator at the University of Michigan who wants to do a pediatric vaccination study looking at different vaccination schedules, hopefully to help inform those schedules for the pneumococcal vaccine in low and middle income countries. And so I'm very excited to start to put our more formal network to use and get her connected with our data sources around the world. So just to recap, we in OHDSI are very passionate about our mission, which is to collaboratively generate evidence that promotes better health decisions and better care. We really believe that as the immense amount of observational health data continues to grow, that we need to be moving in this direction of data standardization, methods research, and open source development, because unless we work together, we will not be able to put that health data to use as effectively and efficiently and reliably as possible. So that's really what we're doing here. And underlying all of that is the OMOP Common Data Model. So we're really proud that the OMOP Common Data Model has been identified as a content global good. So just to leave you with some final thoughts here, like we've been saying, the Common Data Model is widely recognized as the leading international observational health data standard. Our community, the OHDSI community that owns and maintains the Common Data Model, has over 4,200 individuals from more than 80 countries. And the Common Data Model serves as the foundation for community-led, open source development, data standards, methodological research, and clinical evidence generation. And this model evolves to fit the ever-changing real-world evidence global landscape. So I put some links there as well in case you wanted to look us up, or maybe you would like to join the community. We would love to have you. I've ended a few minutes early because I thought there might be some questions, but I can hand it back to Luciana.
Thank you. Thank you so much, Claire and George. That was such an informative presentation. I appreciate the insights into the OMOP Common Data Model that you've shared with us and the valuable work that's been done to standardize and improve healthcare. I've seen quite a number of questions that have come on chat, and George has been responding to them. I don't know if anybody wants to come off chat and give more detail on their question, or George, from your responses, if there's anything that you'd want to come on and explain further on as we continue to look at the questions coming in.
I see Andy Cantor has a comment.
Hey, George and Claire. I mean, this is a remarkable community of people. And so first, I'm also at Columbia. I work with OHDSI, but I am active in the Africa working group, and have been working along with Digital Square's global good activities like OpenMRS, Open Concept Lab, OpenHIE, and so on. One of the things that I was so amazed about was this incredible community of people, open source software, and a method for essentially delivering evidence from real world data, observational data. But what was clear was that there wasn't a lot of low and middle income country representation. And so one of the hypotheses that we had in the Africa working group was that the CDM really supplements what currently are the other global goods that deliver sort of interoperable data, particularly in low and middle income countries, like OpenHIE, and the use of FHIR, which really helps move data around, but doesn't always sort of tell you what to do with the data once you get it. And OHDSI does such an incredible job of providing these tools that are really free and open source to look at data quality and to actually answer relevant questions about the data, which FHIR doesn't really do. And so it's kind of an important supplement. And so the hypothesis was that the CDM, when added to OpenHIE or to national health information systems, could make the data that's already being collected within countries more standardized in a way that would allow them to not only do what they need to do in their countries to answer important questions about healthcare, but also allow those countries to participate in this sort of federated, private way in global efforts to deliver evidence and knowledge. So, countries that traditionally had been sort of invisible to the research community would be able to participate in a safe and effective way. And so this is kind of hypothesis, and that there is been efforts, for example, in Malawi, where they've actually set up an OMOP CDM version of their national healthcare data. Rwanda has done as well, where 16 hospitals combined their data into the OMOP data model for COVID research. And so I think there's really an interesting synergy here between the research community and the general health information management community that has been struggling for so long to get better quality data and to really improve representation and equity in research and in healthcare. And so I think that's why this is a particularly valuable addition to the suite of global goods that are already out there.
Thank you very much, Andy.
Yeah.
Let's see, we can, and I agree. And thank you for your support over the years and help. And we're answering questions in the chat in simultaneously. Yes, ICD is a terminology, and what OHDSI does is so when you have a code in ICD 9 or 10, it gets stored in the database as a source code of what we started with, and it gets mapped to, usually it depends on what that ICD 10 code represents. Usually it's a diagnosis or something, and it would get mapped to SNOMED CT, and that's what gets stored in your database. That's the vocabulary side of it. OMOP, remember, is the schema, the structure where you put it in, and then you could include the vocabulary with that. So that's really, ICD doesn't tell you where to stick it in a table. It's just saying, here's what diagnosis I'm representing right now. So anyway, we map from ICD to SNOMED and from read codes to SNOMED, and we leave SNOMED as SNOMED. And there are other vocabularies. And remember, there's ICD-10, say in Europe, and there's ICD-10 CM in the US, and they're both mapped to SNOMED. So what we've for diagnoses say. So what we've accomplished is that we don't have to, in real time, when we're doing a study, worry about whether someone used ICD-10 CM or ICD-10 or ICD-10 Germany, or the read codes in the UK, or other coding scheme, but they're all mapped to this one thing, which happens to be SNOMED CT for the what we call the conditions, which are diagnoses for the most part.
Yeah, so there was a question about, the Themis repository. So this was something we developed this year in 2024 because we realized there were many common questions that came up around how to map certain types of data to the CDM, or what to do if. So for example, in the OMOP Common Data Model, when you have a drug exposure, the drug exposure end date is required. But many people said, well, what if I don't have a drug exposure end date? And so we do have an answer for that. And we have many answers in the Themis repository. So this was a way for us to kind of write a little bit more related to some of those questions many people have. A big one, I think I put it in here, gender identity. Many people have information on a person's gender identity. And so we wrote an article about how to map that data and what to do with it. There's a question. Let's see. There's a question about development pathways of OMOP. Can you elaborate on what you mean by development pathways? And then while we do that, there was a question about open MRS to OMOP. Andy, do you have any
Sure.
information on that?
Yeah, so that is actually the primary source of the data within sort of the OpenHIE community that we've turned into OMOP. The Malawi digital lake, I forget what the actual Opens Health Data Lake, I think is what they call it, leverages the OpenMRS schema to drive their conversion of OMOP into OMOP. About 60% of the Rwanda data that I mentioned was in OpenMRS, and there's currently a project going on in Kisumu to translate their primary care network data, which again, 3 million something patients, all in, well, it's something like 60 to 70% within OpenMRS. So those we're trying to document and make those available to everyone as kind of a resource for sure.
Thank you.
Hope that answers your questions, Peter.
So the elaboration on development pathways is ways of improving OMOP for the future. In terms of the model, yes. So like I was saying, we do have our kind of development pathway or our cycle there. What we've actually really been seeing over the last few years is a lot of what we call OMOP CDM extensions. So for example, there is a medical imaging extension. So if you have imaging data, there is a group within the OHDSI community that has developed different tables and vocabularies to map medical imaging data. Now, these tables and fields aren't necessarily what I call in the canonical CDM. So the canonical CDM was that entity relationship diagram I shared, but these tables are owned and maintained by other groups within the community. And what we have decided is as more people start to use these extensions, then if they gain a large traction, we will incorporate them into the canonical CDM. But what we found is if we add too many tables too fast, our global community has a hard time keeping up with the changes, and then it actually does more harm than good. So the extensions are the ways that we are trying to, we're trying out new tables and options for representing data without having to move the entire community in that direction. So for example, we have GIS, a GIS extension for like location-based data. Like I was saying, we have medical imaging. There is an oncology extension, and that extension has been added to the canonical CDM. There was one recently done for extracorporeal life support, and they actually don't really want it necessarily back into the canonical CDM, but that group wanted to create tables that aligned with the OMOP standards, so they could potentially integrate with the OMOP CDM, but also map their own data. So we are certainly looking to improve the model as we go. So there's a question around the steps to align system data to OMOP. How can we start? That's a really good question. So the first way you would start is to actually map your data into the Common Data Model. Like I was saying, there's the Book of OHDSI that has some information on that of like how you might start to generate that logic to map your data. And then also the Eden Initiative has an academy. I'm going to put the link in the chat, academy.eden.eu. This academy actually has lots of trainings, like open trainings available, so that, if you wanted to get started, you could start with the Common Data Model training, and then there's one on ETL that goes through the different steps. And then we'll take you all the way through evidence generation.
It looks like we're at time now.
Mm-hmm.
I think, and I will need to sign off, but we are open to answering email, any other questions, or better yet, join the OHDSI community and post on the OHDSI forum. That would be an ideal way to become an active member of the community.
Yeah.
Okay, thank you. Thank you, everybody. Thank you, audience, for participating in this. And thank you, Claire and George, for presenting. presenting OMOP, and we will see you next month for our last webinar of the year, which will be Dimagi presenting on the Data Privacy and Security Handbook. So thank you, everybody, and have a great rest of your day. Bye.
Thank you.